In this video, I want to discuss attention deficit hyperactivity disorder, or ADHD. So ADHD is extremely common psychiatric disorder in children. Its prevalence is somewhere around 5 to 11% of school-age children, and if you have plans on working with child-adolescent psychiatry, then you better really get good with this diagnosis, and you also better get good with the treatment, because a large part of what you will probably be seeing, especially in outpatient clinics, will be evaluations for ADHD. It presents with several core symptoms, and those core symptoms include things like inattention, hyperactivity, and impulsivity. The diagnosis can be further characterized based on the primary symptoms, so you can give specifiers. You can say it's primarily hyperactive, primarily inattentive, or combined. The diagnosis has to include 6 signs and symptoms of either inattention or 6 signs and symptoms of hyperactivity or impulsivity for at least 6 months. And the other important point that you're going to want to know besides that one for your boards, you're also going to want to know that for people above the age of 17 or older adults who are getting diagnosed, they actually only have to have 5 of these core symptoms in order to be diagnosed. So actually the number of symptoms goes down, which is kind of counterintuitive. You think you would maybe need more in order to diagnose ADHD in an adult, but that's not actually true. So the key things from this particular slide are to remember that the diagnosis has to include 6 signs and symptoms of inattention or hyperactivity and impulsivity, and it has to be present for 6 months. And you want to know that for 17 years and older, that only 5 of the symptoms have to be present in order to make the diagnosis. Let's go over some of those symptoms of inattention to start with here and just get a feel for this. Now, this is very, very challenging aspect of diagnosing ADHD because a lot of these symptoms overlap a lot and they're very redundant, and it can be difficult to memorize all of them when you're doing, say, an evaluation for ADHD. What I like to do and what I suggest you do is you actually just print out the symptoms from and the criteria for the diagnosis from the DSM-5, and you go through it one by one with your patient to be sure that you're not missing anything or making any mistakes. But anyway, some of the symptoms of inattention include things like failure to pay close attention to details. These patients will have difficulty sustaining attention to tasks or activities. They'll have a failure to listen to when spoken to directly. They'll have some difficulty organizing their tasks. They may avoid certain activities that require intense mental effort. They may lose things necessary for tasks or activities. They may be incredibly distracted or easily distracted, and they may also be forgetful in daily activities. So these are some of the symptoms of inattention. The next set of symptoms are the hyperactivity symptoms. And the hyperactivity symptoms are more of like the motor symptoms. So this will be where the child is fidgeting with their hands and feet all the time. They can't sit still in their chair. They tend to be running around when it's not appropriate to be running around. They have some difficulty engaging in any kind of quiet or leisurely activity. They may describe for you or tell you that I feel like I'm always on the go, I feel like I can't stop moving, or like I'm driven by some kind of motor, and they may also be talking excessively. The final set of symptoms to start thinking about with ADHD is the symptoms of impulsivity. So with impulsivity, a lot of times we see this in school. They'll be blurting out answers to questions before the questions are even completed or fully asked. They'll have trouble waiting their turn to answer questions, let's say, or waiting their turn in lines, etc. And they may also frequently interrupt other people when they're talking. The next thing you want to look at is the diagnosis specifiers. So as I was alluding to earlier in this discussion, I said that you could specify it as either the combined type, so that's where you have both the inattentive and hyperactive impulsive symptoms, or you can show that it's predominantly or specify it as predominantly inattentive or predominantly hyperactive or impulsive, depending on how the patient presents. The pattern of behavior also has to be severe, so that when it's observed in other children of the same age and developmental level. So basically what you want to see here is that you want to make sure that this is just not normal childhood behavior. So one of the things that's very, very difficult to deal with, especially when it comes to behavioral issues, is determining, is this pathological or is this just normal child? Is this a kid being a kid? Because it's quite possible that these things are not pathological when you see them. So they have to be compared to children of the same age and developmental level, and show that these symptoms of inattention or impulsivity and hyperactivity are much more severe than that of the average child the same age and developmental level. The symptoms of the disorder must be present before the age of 12 years old, so that's really important. The children can be diagnosed after the age of 12, but the symptoms must have been present prior to 12 years of age. So another important board testable point that you want to remember is that these symptoms have to have been present before the age of 12 years old. And the impairment also has to occur in at least 2 settings. And the classic examples of the 2 settings are home and school. So you will need to get collateral information from the patient's teachers and to determine whether or not they're having these symptoms in school, or is this just at home, or is it only in school. So it has to be in at least 2 settings. And the symptoms can't be exclusively present when another disorder is present. So it can't be someone like the child has maybe suffering from depression, and is during that time having difficulty concentrating in class. So you want to make sure that it's primarily due to this disorder. The prevalence of ADHD, so again, prevalence is between 8 and 11% among school-age children. The disorder persists into adolescence and adulthood in about half of those who are affected. So about 50% of people who are suffering from ADHD will actually have symptoms that continue into their adulthood. The male to female ratio is approximately 4 to 1, so it's predominantly the hyperactive type, and 2 to 1 for the predominantly inattentive type. So male to female ratio is always greater, but it's much greater in the predominantly hyperactive type than in just the predominantly inattentive type. Some of the treatments for ADHD. So some of the treatments for ADHD, the first line is medication. So people kind of question this, and you hear a lot of times in the popular media, like, why are we medicating all these children? Well, if you go back and you actually look at the data and you look at the research, what it indicates is that the medication has had the best efficacy, even far greater than just simply behavioral interventions. And I'll dive more deeply into that here. So medication's first-line treatment for ADHD in school-age children and adolescents. There's a 70 to 80% response rate to psychostimulants. That includes things like methylphenidate, dextroamphetamine, and amphetamine salts. Now, for the preschool-age children, being those under 5 years of age, it's actually a little bit different. So for kids that are preschool and are exhibiting these symptoms, then we want to maybe try behavioral interventions as a first-line treatment and see if that helps the child. If not, then once they become school age, you can move on to the medications. The medications can be considered for preschool age children if the behavioral interventions fail or the functional impairment persists or is very, very severe, in which cases you want to think about medication even for preschool age children. And now a little bit about the specific medication types. So the most common and well-known are the psychostimulants. Those include things like methylphenidate, which is Ritalin, and that should be started at about 2.5 to 5 milligrams twice daily, and they would normally take that medication before breakfast or before lunch. If needed, you can actually increase the dose weekly, and that increase can be up to 2.5 to 5 milligrams per day, and you want to reach that optimal dose of about 1 milligram per kilogram per day, with a maximum dose of 2 milligrams per kilogram per day. There are some side effects to taking stimulants, so there's things you want to watch out for. Some of those side effects that you might realize would be kind of intuitive with psychostimulants would be things like insomnia, decreased appetite, mood disturbances, tics, headaches, GI distress, and in very rare cases there can even be some signs of psychosis. Longer-acting methylphenidate preparations are also available, and those things include Ritalin XR, Ritalin LA, and Metadata CD. So there's a bunch of different long-acting preparations as well. So you're not just stuck with the shorter-acting ones. The next psychostimulant is the amphetamine sulfate, which is Adderall. Probably one of the more common drugs that we're familiar with for ADHD. It should be started at approximately 2.5 to 5 milligrams once or twice per day, and it can be increased by 5 milligrams per week, reaching that optimal dose of somewhere around 0.5 to 1 milligram per kilogram per day. Dextroamphetamine is twice as potent as amphetamine, And amphetamine has very, very similar side effect profile to methylphenidate, that being the things like the insomnia, the tics, the GI disturbance, the decreased appetite, etc. Longer acting amphetamine preparations are available as well. There's Adderall XR, there's dexedrine, and there's Vyvanse, which is formulated as a prodrug to reduce the risk of abuse. Both of these last approximately 12 hours. So you're looking at about a 12-hour run with those preparations, the longer acting ones. The next psychostimulant that we'll talk about, or the things that we'll talk about with psychostimulants here, is that these psychostimulants actually carry a black box warning. And the black box warning is, of course, in regard to dependence and abuse. In addition to the dependence and abuse potential, we're also learning that there's some cardiovascular safety warning that was issued recently by the FDA as well. And that is for the risk of sudden cardiac death. So you want to make sure that any children who have structural heart defects or other serious cardiovascular conditions, you may want to reconsider using these medications because there is some risk of sudden cardiac death. And the patients should ideally be screened for any kind of personal or family history of sudden cardiac death. And you should always do a physical exam on these patients. The EKG is kind of questionable if there are any signs or symptoms that the patient's exhibiting during the physical exam, then you want to do the EKG. But the EKG itself is actually not required in the absence of any kind of cardiovascular risk factors. The next medications to talk about for ADHD are the non-psychostimulants, and some of those medications are actually antihypertensive medications, including the alpha-2 agonists, which can be used in ADHD and also can be used if there's any kind of comorbid aggression. So some of those medications include things like clonidine, and that can be initiated at about 0.025 milligrams BID, and it can be dosed up to 4 to 5 micrograms per kilogram per day. So that's one choice that you have. Side effects of clonidine include things like sedation, depression, and rebound hypertension. The other one is guanfacine, which is similar to clonidine. It's also an alpha-2 agonist, but it's less potent and there's less sedation. So this is the one that's kind of preferred over clonidine, and its administration can be dosed up to 1 to 2 milligrams TID. Atomoxetine, or Strattera, is a selective norepinephrine reuptake inhibitor, so again works by a different mechanism than your psychostimulants and then your antihypertensives or alpha-2 agonists. For those under 70 kilograms, the starting dose is somewhere around 0.5 milligrams per kilogram per day, and that can be increased at least 3 days to the target dose of 1.2 milligrams per kilogram per day. And for those above 70 kilograms, the starting dose is 40 milligrams with the target dose of 80 milligrams and a maximum dose of 100. Side effects include GI disturbance, sedation, decreased appetite, and irritability. The other thing that you really want to know about atomoxetine is that there is a black box warning for liver injury. And that pretty much wraps up the discussion on ADHD. Hopefully this was somewhat helpful for board preparation or just general knowledge.